Hi, everyone. It's a pleasure to be here. I'm grateful to Lindsay and Jim for the invite. It's a big topic, and I'll try to give it justice in the next few minutes. Obesity medication have changed the landscape of the last few years. If you look at this slide, at the top, we have lifestyle intervention, which on average achieve 4 to 7% weight loss at 1 year. At the bottom of the slide, we have bariatric surgery, which achieve around 30% weight loss at 1 year. 10 years ago, we would only have orlistat, which an lipase enzyme inhibitor, which affects fat absorption. It led to modest weight loss with significant side effects. Saxenda, or liraglutide 3 mg, was the first GLP-1 to be approved for weight loss and came to the market and achieved a modest weight loss. In the last few years, some more potent GLP-1s came to the market. We have Wegovy or semaglutide, which is a GLP-1 analog therapy, and Mounjaro or tirzepatide, which is a combination of GLP and GIP-1 receptor agonists, both achieving significant weight loss and bridging the gap between lifestyle intervention and bariatric surgery. The average weight loss here is compared to placebo, to the total weight loss is more. How do these medications work? GLP-1 and GIP work both on different areas in the central nervous system. They induce satiety, they reduce hunger, and they lead to reduce weight. But also the GLP and the GIP receptors are in many other organs. So they have peripheral actions. For example, GLP-1 reduce gastric emptying. Both medication will increase insulin sensitivity, increase insulin production from the pancreas. Their main side effects are gastrointestinal, including sickness, diarrhea, constipation, which lead to discontinuation of the drug in 1 in 10 individuals. The benefit of these drugs was highlighted previously, and it's spread outside weight loss. For example, both semaglutide and tirzepatide achieve between 20 to 30 millimole per mole reduction in HbA1c, which is highly significant. In the SELECT landmark trial, semaglutide achieved reduction in major adverse cardiovascular event. And it's worth noting that the difference between the placebo and the treatment group was noted after a few months of starting the treatment, suggesting probably a weight-independent pathways. Tirzepatide in the SURMOUNT obstructive sleep apnea study showed significant reduction in apnea-hypopnea index score, which is a marker of severity of obstructive sleep apnea in both people using CPAP treatment and not using CPAP. Both medications have shown effect in heart failure, with improvement in functional capacity, quality of life, and with tirzepatide, it showed reduction in admissions with exacerbation of heart failure. The benefit goes wider than that, including renal function, blood pressure, inflammation, fatty liver. But where are these medications used at the moment? A paper published recently showed that on average, around 3% of the adult population in the UK have used GLP-1 based medication for weight loss in the last year. That is around 1.5 million. Of those, 90% have used it privately, and only 10% have used it on the NHS. Now, if we look at the gap, we see the license of the medication. The license in the medication means that everybody with obesity will be eligible for this drug, or they could be prescribed to, and many people with overweight if they have an obesity-related comorbidity. That is the license, which probably more than 30% of the adult population within the UK. Now, if we look at this at NHS prescribing in specialist weight management services, you can get these drugs if you have a body mass index more than 35 and 1 obesity-related comorbidity. I expect 7% of the adult population will fit this criteria, but 7% are not accessing this drug. And the reason for that is there are areas in the country where there are no specialist weight management services. But also, where these specialist weight management services are present, they are overwhelmed with referrals and demand that many of them had to close their doors for new referrals, or patients had to face many years of wait to access this medication. Now, what happened in the last couple of months? A significant change, which allowed primary care to start prescribing these drugs in the community. And I feel this is the place where this medication should be prescribed. Now, NHS England felt the impact if they allowed everybody to access this medication, and we're talking about the population in the middle to access it through primary care. They felt it will overwhelm primary care. So they decided to make it gradual over a 12-year period. So in the first year, only people with body mass index more than 40 and 4 obesity-related comorbidity will be able to access this medication from primary care. In the BNSSG, in the Bristol, North Somerset, and South Gloucestershire area, we expect around 1,000 people will meet this population. However, it's a good news because next year, the BMI will drop to 35. And the year after, the number of comorbidities may drop to 3. So what we are talking, it's a gradual process to allow easier access to this medication. Where does obesity sit within the government? If we look at the 10-year healthcare plan for England, obesity sits very highly, and there's a big ambition from the government to tackle obesity. And I think that's all positive. When I looked at the document, in particular, I focus on what areas related to medication. There are a few areas. One, they talk about using genomic to achieve personalized care, to prevent obesity, and find intervention to reduce its occurrence. Two, they talk an innovative way in partnership with private providers, with pharma, to see how we can deliver the best way. They talk about digital-only access, pharmacy-initiated access, community-based clinics to make the access easier. They talk about industry partnership and to make the UK a place, the favored place for obesity research in the world. And they also talk about focusing with pharma about how best to deliver these drugs, but also to change the payment from payment by weight loss to payment by outcome. For example, the payment might be linked to a reduction in cardiovascular event, reduction in cancer, reduction in diabetes occurrence. At the end, there is a commitment of the government to reduce inequality. And in that, they appreciate that currently the way it's happening, it's inequitable. So they in their plan, their aim is GLP-1 based therapy for obesity should be able to be accessed in a timely manner and at a large scale. With more than 1 billion people with obesity worldwide, and with a market of obesity more than $100 US over the next few years, it's no surprise that the obesity market is thriving. Obesity research and development is thriving. We heard about how many medications in the process at the moment, more than 100. In this slide, I can only show some of the medication which are currently expected to be approved in the next few years, and these are GLP-1 based. However, not all the medication in development at the moment are GLP-1 based, and others are working through completely different mechanisms. On the right side, we can see the average weight loss. And what we can see that we're moving away from the 5% weight loss. We're talking 15, we're talking 20. One of the new drugs by Eli Lilly, which is a GLP-1, GIP, and glucagon receptor, achieved nearly 25% weight loss. I also would like to highlight the complexity of obesity and our limited understanding. For example, tirzepatide, which achieves significant weight loss, is a GLP-1 and a GIP agonist, while maritide is a monthly injection, and it is a GLP-1 agonist and a GIP antagonist. How can both work and achieve significant weight loss more than GLP-1? Again, similar to what was mentioned, there is oral GLP-1, there is once weekly, there's once monthly, so the landscape is changing. So what are the potential areas for medical research in the future? And it is completely wide, but we're going in the future to think about newer pathways outside GLP-1. We'll be talking about novel drug delivery. We'll be talking about what are the long effects of this medication. The longest trial is probably 4 years. But what happens if somebody takes this medication for 10 years, 20 years, 30 years? We will be talking about combination therapy. At the moment, it's either Wegovy or tirzepatide. But in the future, we'll be talking about combination therapy. We'll be talking about how this medication work in selected population. For example, people with end-stage renal failure, people with mental health disease. We want to know how they work in different populations. We want some health economics to justify their wide use and justify their high cost as well. We know that 30% of the weight loss achieved with GLP-1 is due to fat-free mass. How can we preserve the muscle mass? And what intervention there to preserve fat muscle mass for the future? We want to use AI, big data, large-scale genetic sequencing to find individualized care, look at newer pathways and new ways of working. So in summary, the new medication will reshape obesity management in the UK. Unequal access to therapies is a significant challenge to equitable healthcare. Ongoing research and cross-sector collaboration promise more personalized and effective treatment. Collaboration and policy reform are essential to integrate pharmacotherapy into a comprehensive care model. Thank you.